All right, we're going live here. Hello, everyone. Today we're going to be joined by Dr. Joel Aronowitz. He's a plastic surgeon in Beverly Hills. I think he's joining us right now. He has a celebrity list clientele, so we're excited to talk to him, and we'll be answering some questions at the end. Here he comes. And I appreciate all the questions you guys have sent in advance of this, and we'll go through all of them as well. Is he coming on? Okay. Hi, everyone. Hi, Alyssa. Hi, Joanna. Just waiting on Dr. Aronowitz to join us. You think maybe it's a Wi-Fi issue? Hi, Abby. There you are.
Oh, there I am. Hi.
How are you?
I'm good.
Are you gonna hold the phone?
Oh, I'm gonna hold the phone. I have to hold the phone.
So we're
good to
we're
see you,
officially
Paul. Ask Chloe to send you the questions we got. Okay. All right.
we're officially in Aronowitz land. We're all excited here in Texas to be in sunny California with you.
No,
My son is FaceTiming me. Sorry.
no worry. No worry. So it's really nice to have you. It was a great idea. I think it would be great if you could tell a little bit about yourself while we're waiting for people to log in. And I'll just say that you're living my dream of being in the Texas Medical Center there. I was there during the 80s, which for those who aren't as old as me was the last time oil was $10 a barrel. Was 1986, so I left in 87. The Texas Medical Center is really a fantastic place to practice. It was a wonderful place to do my training. And Houston's a great city, and I still miss it a lot. So glad that you're out there. And you've made a wonderful life for yourself and your beautiful family. And
Thank you.
Everyone, all of my doctor friends in Houston speak very, very highly of you, Paul.
Well, thank you. And for everyone listening, Dr. Aronowitz practices in Beverly Hills, and he has a A-list clientele. Will you tell us a little bit about what your kind of go-to procedures are for, I know you do a lot of wound care and do a lot of breast reconstruction, but in terms of elective procedures, or what would you say are your
Sure.
procedures?
So I do a full range of plastic surgery, and I do a lot of breast surgery, a lot of breast reconstruction, and nipple sparing mastectomy, and what's called oncoplastic reconstruction, which is basically using plastic surgery techniques applied to breast cancer so that the breast cancer results have natural, minimal scarring kind of results. And on the elective side, totally cosmetic, I have, I would say, probably the usual kind of practice for somebody in my stage of my career: facelifts, minimally invasive facelifts, using different updated techniques with smaller scars and internal support, internal slings. For breast, the niche is fat transfer, taking out implants when they've been in a long time and women are tired of the implant, replacing with stem cell enhanced fat. Basically what we do is we augment the fat with additional stem cells from the person's body. And then mommy makeover kind of things like tummy tuck and liposuction and fat grafting to the bottom to fill out the bottom is very popular now.
So could we talk a little bit about, because, as you know, there's probably the number one request that I get in my practice is a natural look. And I've seen your results. I mean, I've had the opportunity to work with you in your office, and I think what's remarkable about what you do is how aesthetically natural the results are. I mean, I think a lot of patients coming in, and I'm sure you hear this on a daily basis, their concern is that they're going to have a pulled look. It's not going to be age well with time, and so a lot of patients who come to me are looking for non-surgical options. So I'm curious from your perspective, knowing that there's all these non-invasive options, at what point do you recommend intervening with a surgical approach, or are you gravitating more towards injectables and energy-based tightening devices?
Well, both. I think the demand from patients is more along the lines of less and less invasive procedures. There's no question. And the energy-based devices that basically deliver heat in some form or another to the undersurface of the skin and to subcutaneous fat in order to accomplish tightening, they've gotten a lot better over the years. But they're still not perfect, and they're still not a way to tighten the skin evenly and reliably in somebody whose skin is really loose, to to replace surgery. We're just not there yet. For somebody who's
So
marginal, do it.
what would you say is the average age of your patients that are electing for perhaps a lower face or neck lift? If you had to give me an age range, because I can tell you the average age of my patients are about 47,
Yeah.
who are coming in. I mean, they're getting younger and younger now, which is, I think, a
Yeah.
effect of all this screen time that we all have, and selfies and social media. But I'm just curious, from your perspective, people are coming to you for surgical treatment options. At what age are they coming in, and at what point are you recommending the procedure?
Sure. There are very few people in their 30s who need facelift of any form, and I totally agree. And by the over 45 is a I would say an average, but there are people in their early 40s who would benefit from usually
Wow.
a lift or a minimally invasive facelift.
Wow. And then at
Yeah.
what point will that, okay, so if you're looking at somebody in their 40s, when would they typically expect to require additional procedures? My first question, I have a lot of patients who come into my office who have had a facelift and are looking for ways of augmenting it, or perhaps the skin wasn't addressed, so they're still dealing with the sun damage associated.
Hmm.
Perhaps as based on the technique of the facelift, they might have some volume loss here laterally, that I find that I'm doing a lot of fillers in that area to restore some of the volume loss. So when you're doing facelifts in that demographic, are you also doing fat transfer, or are you at concomitantly?
Very common, and I'll usually do stem cell injections, even if volume isn't necessary. I will do stem cell injections, and the stem cells are coming from that patient's own fat. Most people need a little fat in the upper face, even if it's only 10 or 20 cc's of fat. And I think it's a good point in the conversation to point out that what we know about facial aging related to fat redistribution, that basically what's happening with age, we know, is we're losing fat from the upper part of the face and we're gaining fat here in these parentheses. That's the basic pattern. So what happens is we lose fat here and we gain fat in these parentheses. So we gain fat here, we gain fat here, and we lose fat over the cheeks, and we lose fat in the temple. We lose fat in the subcutaneous fat under the eye. So what happens is we get a general squaring off of the face. So many times a man looks better with age because his face becomes more masculine. He becomes more squared off. And a woman, it's, her face squares off and she doesn't look better. That's the pattern of fat redistribution with age. So replacing some of that fat from those areas we've lost it from is helpful.
So I'm curious, what I see a lot of patients coming in are patients who are very athletically fit. They're runners. They also, I would say a majority of patients are coming in are teeth grinders. They have a history of bruxism. And so, I'm curious how you feel like over time that causes lateral bone loss, because I see a lot of patients where you start to get a little bit of lateral bone loss, and they have that history of teeth grinding. And I'm wondering if you feel like there's an association there.
I don't think so. I'm not knowledgeable about of any studies that demonstrate that.
Okay.
I would doubt it, because if you're putting more strain on the bone usually thickens, not weakens as a result. But the answer is I don't know.
Okay. So in the patients, when the patients are presenting to you based on their weight, I mean, does that play a role in the recommendations that you make? If somebody's going to, say, be losing weight over the course of the next several months, would that affect at what point you would recommend any sort of surgical procedure?
Yeah, I mean, I'd prefer somebody be at a stable weight. I don't think, I'm laughing at Bridget's making faces at me, but behind me. There's Bridget, everybody. Say hi,
Hey.
Bridget.
Oh, sorry. I'm listening and monitoring.
She's monitoring me to make sure I'm not going off on a rant or something.
I enjoy all y'all's videos together. They're great.
Anyway, I forgot what you asked me.
You like somebody to be kind of at their ideal body weight, or at a...
I never tell people to lose weight. Sometimes I'll tell someone to gain a couple of pounds if they're planning on losing, if they've lost too much. But I would never, I think it's counterproductive to tell somebody to lose weight. If they were going to lose weight, they would have lost it already. And I think it's better to deal with the person as they are. As long as they're at a stable weight, there's most things you can solve surgically.
Right. All right, I have some questions that came in. Do you have some questions too?
I do. Do you have the questions that Chloe?
I have some questions.
Okay.
What are you looking? Oh, okay.
I was looking for my wallet.
All right. Let's start with this one.
Okay, we've got the questions coming here.
Hyperpigmentation. Do I try it? No, I don't need to be on it.
What? Come around.
Come on, Brigitte. We want you on.
Come on.
All right.
Everybody would rather see Bridget than me anyway.
No, that's not true. All right.
Hi, Bridget. Nice to meet you.
Nice to meet you.
Bridget, did you know that Dr. Friedman, I don't know if everybody knows that Dr. Friedman isn't just an old friend of mine. Did you know?
That he's your...
He's my cousin.
Yeah, I know. It's amazing.
He's from the side of the family that isn't in insane asylum. I don't...
All right, let's keep.
Robin's on the call, by the way.
Hi, Robin.
This woman has hyperpigmentation. Should she go with a peel or a laser?
And where's the hyperpigmentation?
I'm gonna say face.
Face.
And do you know what causes it? Go ahead.
No. Oh, due to sun damage.
Sun damage.
Yeah.
So
yeah. So I think we all choose our tool based on what's in our toolbox. I mean, having the experience that I have with lasers, I'm very comfortable treating hyperpigmentation with lasers, but I'm very, very cautious. I typically will pre-treat the patients with a skin brightener. We like topical hydroquinones. More recently, we've been using a lot of topical tranexamic acids. We also will counsel patients on the importance of avoiding the sun both before and after the procedure. And typically, we like a laser called the Clear and Brilliant Permea, which is very low energy, low density.
What?
And it's called the Clear. Yeah, and we use it. I can show you some pictures. We use it. We see a lot of patients who have had hyperpigmentation for a variety of different reasons, and we've had success. And then another topical that I really like, since you guys are in the plastics arena, do y'all ever use Triluma cream? It contains it contains a hydroquinone, a retinoid, and a topical steroid, and it's just a wonderful formulation to pre-treat patients with hyperpigmentation to kind of prime the skin. And then if they don't respond, then we proceed with a low energy, low density laser.
Interesting. Would you suggest that for melasma?
Yes, I use the same approach for melasma. We're also doing a lot of oral tranexamic acid as well for melasma. I have a question for you guys now. Let's see here. Question is,
Put them in the form of a multiple choice because
That's all
I'm
I
good
do
at
well
multiple
at.
choice tests.
okay, I have stubborn fat pockets on the side of my knees. Do you guys recommend cool sculpting, or what do y'all recommend? Or obviously, you probably lean towards liposuction, I
Yeah,
imagine.
I like cool sculpting a lot because it actually works. It's one of these machines that actually works. And so if I would say to anybody listening, if you go and have a consult for cool sculpting and they say they can do it, then I would, in general, it's very safe, minimal complications, and it does actually work. It's not as effective as liposuction, but it does actually work. So can you do knees? Do you have
So
a
knees, you can do. There's different sizes.
She's laughing because I'm putting her in the picture.
Um,
We have to maintain social distance or else
I see
my
that.
can't, be that close to somebody.
knees are tough. Sometimes the area is too small for the applicator, but you've lipoed some knees.
Yes, definitely you can lipo knees, very effective and minimal recovery.
So it's really interesting to talk to you guys about that because obviously, just from a cost saving standpoint, I mean, I would imagine, if you're talking about, especially doing larger areas, that you would have to think that liposuction would be a more cost effective way of doing it in terms versus something like cool sculpting. Would you agree, or are there just some patients who don't want the downtime, in your opinion?
Yeah.
It's usually they don't want surgery. It's usually not the cost. It's usually they don't want surgery, and
Okay,
they would consider a non-surgical option, but they wouldn't consider a surgical option.
got it.
All right, another one. What about how do you deal with a person having stretch marks all over the body due to sudden gain or loss of fat?
Yeah.
So so I assume that they're new stretch marks. So those are usually red. We refer to them as stria rubra. We love the pulse dye laser. It's a very safe laser. We use it actually in 5-day-old babies with vascular birthmarks, but there's a lot of data from the late 90s up until today using pulse dye laser treatment for a variety of different types of scars. And a stretch mark is a form of a scar, a superficial scar. And they do very well. It has a cooling mechanism, a cryogen cooling mechanism that's used. It makes it very safe and effective. And we use low energies. And we have a lot of success improving both the redness and the texture. Now, for more mature scars, what we call stria distensa or white scars, where there's more of the texture regularity, we do a lot of the Fraxel laser, again at low energy and low densities, to help with stimulating collagen and improving the appearance of the stretch marks. So I have a question for you guys. Question is about what is the best, least invasive procedure for wrinkles under the eyes and crow's feet? I do not want to.
Love it.
Do you have any wrinkles under the eyes?
We were just talking about this. Don't you dare bring that close to me. You know what? All right,
I'm gonna get into so much trouble for this.
These drive me crazy. All right, put it back. Put it back.
She doesn't want me to show her.
All right, we like Botox. We love to Botox.
Bridget doesn't have a wrinkle on her entire.
I do.
Anywhere.
Botox for the crow's feet, and then I just was talking to him about this little, like, the skin is so loose here for everyone, not just me, but for everyone. Okay. We like Botox or like having a good moisturizing cream. He told me to get a humidifier for my room because if the skin is dry, it might show more.
You don't have to do that in Houston.
No.
The climate is humidity now. Especially in LA and other climates that are very dry. Sleeping, you think about it, you're in the bedroom for 8-10 hours per day. Having a humidifier really would help in the long term.
And in terms of blepharoplasty, what are your typical, what are the the demographic?
Someone Bridget's age, obviously, or even up to roughly 35, most people do not have excess skin here, even though you can always pinch some skin. So if they have this puffiness of the lower lids, that's periorbital fat that's bulging forward because of weakness of the septum orbitale. About all the Latin I know, but the septum holds that fat in. If that fat is bulging forward, then you need to take out some of the fat or reposition the fat. That can be done through an incision inside the lid. But if there's excess skin, we need to go subciliary, that is right under the lash of the lower lid, and remove some of that skin.
And are there any energy devices that you like in this region as well?
No, it's pretty much a skin removal. Now, Bridget will,
Microneedling?
Microneedling.
I agree.
I like that.
Bridget, do you do any radio frequency with microneedling? Have you tried that in this area?
I haven't. Have you?
Yeah, we use the Lutronic Genius device in this area, and we're able to usually do about 3 treatment sessions, and it's not going to be as good as what Dr. Aronowitz can do with surgery, but for patients who want a little bit of skin tightening in this area, we've had success.
Someone asked a question on the thing that was like, what do you guys like to use for skin tightening for like the thighs or the knees? Anyone?
I think Suzanne Summers came up with a great device.
What is it?
The Thigh Master.
Oh.
and Suzanne will be happy to send you one.
All right. Well, it was for someone who asked. You could do radio.
It
Exactly.
works. The serious answer is the medial thigh skin up high is very thin. That skin of the upper inner thigh on everybody is very thin. If it gets stretched out, the usual reason is because someone gets heavy and then they lose weight and the skin gets stretched out there. But sometimes it just stretches with age. There's the radio frequency devices that are like the energized liposuction, for example, and the other direct radio frequency devices actually can tighten that skin, and a little bit of irregularity there is very well tolerated. And and that's a very good alternative to a thigh-plasty, which means actually excising the skin, because the scar from that, whether it's up in the groin crease or it's going up and down the way the seam does, the inseam on a pair of slacks, either one of those scars is not very good. And so that's a great place for heavy duty radio frequency, external or the invasive type where they put a little needle in.
Great.
The outer thigh and the anterior thigh, it's not amenable to that, or not nearly as much anyway.
So are you guys doing a lot of virtual consultations right now? Or are you still bringing?
We are doing more than we were before, but we're still open. Our offices are all still open, and the main reason we're doing it is either because the patient is far away physically, or they're just worried about coming into the office. A lot of patients are worried about coming into the office.
So question, how do you tighten skin? We answered that one, right?
You see that?
Yeah, I mean, basically, the way you tighten loose skin without actually cutting it away is you either introduce some type of insult from the outside, which is a burn from a chemical peel, a laser, there are all kinds of energy devices from the outside. And basically what you're doing is damaging the skin in some way so that it tightens, because scar tissue tightens. So you either do that from the outside, or you put a energized device like a needle under the skin, slip it between the skin in the subcutaneous fat, and heat it up with radio frequency, with laser, with ultrasound. Most of them are radio frequency, but you're basically heating it up to a specific temperature that causes tightening without too much scarring. And the problem with doing those things is either damaging the skin from the outside and causing a burn, or causing irregular tightening from the inside so that you have rippling. And so neither one is perfect, but if you only need a small amount of tightening, or it's an area where it doesn't show as much, like the medial thigh, it can be very successful and a good alternative to surgery.
Are you familiar with the ThermiTight device? Have you worked with that one at all?
Yeah, yeah. I like them. I think that if you're going to use that, you need to go to somebody who uses it a lot. These are expensive devices. The machine itself is expensive. So it's important to go to somebody who has experience with it, but also isn't just using it on everybody that they see because they do, because it's, you know, it's an expensive device and the doctor needs to amortize the cost.
Where are you on thread lifts, insta lifts? You're not?
They're very popular. Here's the basic problem with thread lifts. You can disagree with me if you want.
I usually agree.
We disagree about.
We've been disagreeing about everything today.
Today I've been very disagreeable.
We're on different pages.
Keep
going.
She's planning a wedding, so.
That has nothing to do with anything.
I just want to show you.
He is seriously.
Do you see the size of this nugget that she got for an engagement?
Wow.
All right.
Congratulations.
It's over. No.
That is like, oh my God. All right. Thread lifts.
Thread lifts. So you see,
I have to go to my home visit, actually.
Just stick around. Okay. So here you go. Congratulations on your engagement.
Okay. Thank you. Okay.
Very happy for you.
So can you explain that before going into it, we explain the thread lift, that with the actual procedure?
So if you've ever seen it's basically a barbed suture. It's a suture that has a bunch of little cuts, like a French cut green bean, except the cut doesn't go all the way through the suture. So you have like a fish hook little barb every centimeter or two, so that when you can pull the thread through one way, but when you try to pull it back the other way, the barb catches.
Exactly. And so your perspective as a plastic surgeon, I'm curious.
Yeah, there are two kinds of threads. One is permanent and one is absorbable. So you put it in, let's say I wanted to lift this part of my face. So I put it in, and then it'll go in easily this way, but when I try to pull it up, it pulls because those barbs catch. So that's great. That holds it on the inside. The only problem is that is irregularity, because that suture is there and it doesn't have any give, but our tissues are just flesh, soft tissue flesh, which basically is the dermis and the subcutaneous fibrous tissue. And it will change over time, and usually it'll cause a little give over time. And it will, and if it causes a little irregularity or puckering, or if you want to get it out for any reason, you can't, because you can only pull it out this. So you have to make a cut. You have to find it, make a cut, and pull it out this way, because you can't find it up here where you put it in and pull it this way. It'll only go out one way, this way. And so then they started selling barbed sutures that are absorbable. That way, if you have any irregularity, it goes away in a few weeks or a few months. The problem with those, the problem with the permanent ones is it's permanent and they're hard to get out. The problem with the absorbable ones is by the time they absorb, you lose the effect, because the scar tissue that they cause is not enough to hold the tissue up, in my experience. So I don't think they cause a lot of harm, but they're not the answer to lifting problems, generally speaking. I think in the face, there are places for them, especially the absorbable. I would always advise someone to have an absorbable one. Elsewhere in the body, I wouldn't use them at all. Do you agree with that?
I do agree. I mean, we've seen people that have come in with you can see the thread because it's kind of fallen, and then they want the thread out.
A thread is just a suture.
Right.
It's called a thread lip, but the thread is just a suture.
Do you
it's a barbed suture.
Do you do
So we like the temporary ones that we use the Instalift, and I agree. I think in the right patient population for patients who have the realistic expectations in terms of the durability and what they can expect. We in those select patients we've been happy with the outcomes.
Good.
But I agree.
That's
I mean,
great.
it goes back to what you were saying about Thermotite. I mean, it's choosing the provider who has the experience, who has the understanding of the anatomy of where to place it to get the best outcome.
Yeah, I mean, part of the problem with these thread lifts is that, at least here in LA, they're doing them in med spas and in ethnic neighborhoods, and basically they're, you have somebody who is really shouldn't be doing an invasive procedure doing something invasive.
So before the terrible crisis that we're going through right now, what were some of the most common procedures that patients were coming in for, and how do you anticipate that changing now?
I'm gonna go do my home visit. I have to go.
You're going to abandon me?
Yes, but you know what you should talk about is a lot of people were doing implant removals.
Ah,
Sorry.
okay.
Bye,
All right.
everyone. Nice to meet you.
Great meeting you.
Bye-bye.
Congratulations.
Thank you.
Thank you, Bridget.
Implant removals.
Yeah, I mean, so there are a lot of women who had implants, and then by the time they're in there, they have children, and they maybe the woman is in her 50s, late 40s, 50s. The implants are too big, or they've gotten hard, or they're under the muscle and they're uncomfortable. And the patient is the other factor is a lot of times the patient's a little bit concerned about the safety of the implant, even though she understands that there's, basically the science is that the silicone isn't going to hurt you. But they're just sort of done with the whole implant concept. So, but if you take out the implant, now you have a breast that's droopy and doesn't have enough volume. So with a woman who's not very droopy, you can take out her implants and then do stem cell enhanced fat and replace a lot of the implant volume that you lost. You can replace like a cup and a half size. So basically the equivalent of a 250 cc implant. You can't get a 400 cc implant with just fat really, but you can get about 200, 250 and have a soft natural breast. And the other is taking out the implant, doing that fat grafting with stem cells and doing a lift at the same time, which is a nice procedure. And not having the implants, especially implants that have been under the muscle or are very hard, it's a real relief to the patient.
When you're doing the fat grafting and the stem cells in the face, how long are you telling patients they can expect it to last on average?
If the fat that's there at 10, 12 weeks, roughly 3 months, it's there permanently. And it will act like the fat from where you took it. So usually you're taking it from the tummy and love handles, and that's usually where the fat goes when a woman gains weight. So if you lose weight, if you gain weight, the breast will go, you'll gain volume or you'll lose volume, just like you would from the tummy and hips.
Right.
But it's permanent.
Right. Are you doing regular injectables as well in your practice?
Yeah, and Bridget does most of them because people like Bridget better. She's more likable than I am. But she's doing most of the injectables. I still do a few injectable patients, but she's doing most of them. And somebody's asking if I'm seeing patients in Houston. I'm not coming to Houston regularly. I can see people virtually, but there are a lot of really top-notch plastic surgeons in Houston. I can tell you.
Who do you like in Houston? I get asked that on a daily basis.
There are a lot of really good people in Houston for like rhinoplasty. Mike Eisman, for example, is very good. There are a lot of top-notch cosmetic surgeons. Frank Rose is an excellent surgeon for liposuction and other in breast and body. problems as well as facelift. Michael, oh gosh, I'll tell you what, anybody who has a question about a plastic surgeon in Houston, I probably know them since I was there for years and trained there. You're more than welcome to text me, to IM me or email me, and I'll be happy to give you my take on them. But there are a lot of really good plastic surgeons, especially in the medical center in Houston. I think one of the lucky things about living in Houston is you have excellent medical care. Even at the smaller hospitals in general, the medical care is at a very high quality in Houston.
So are you open? When are you opening up for elective procedures?
Well, I think that I really think that I really think from a practical standpoint, we could do elective procedures yesterday. The answer is next week, I think.
Okay.
We're some low intensity of elective procedures. Here in Los Angeles, the hospitals are at 25% capacity. The emergency rooms are at 40 to 50% of their normal volume. There's really not been a huge surge of virus patients. And I think we'll have another surge of virus patients after we open up a little bit more. But the studies here in Houston, here in LA, show about a 5% prevalence of the virus, which means that the morbidity and mortality of the virus is relatively low, more like a bad flu season. So I don't think there's going to be a huge surge.
And then in terms, I think I lost you there. In terms of, I know we both.
So next week, basically.
Right. Yeah. We're thinking about. Right now, we're deciding it probably will be more like a couple of weeks here. But I'm just curious. We both practice obviously, universal precautions and do. Sterilization techniques between patients and in terms of cleaning everything down that patients handle on a regular basis. Do you anticipate doing anything differently now when operating in this area per se?
I think that basically we treat everybody as though they have hepatitis B, hepatitis C, hepatitis D, HIV, antibiotic resistant bacteria. Basically, you have to assume that everybody has something for the sake of your staff as well as your patients. So, and this virus is no different, basically. I think that there will be some differences just to make patients feel more comfortable. I think part of what we have to do is help patients feel comfortable being in a doctor's office, and for the hospital, I think the hospital needs to help patients and visitors feel comfortable. And so I think there will be a bit of what I call viral theater, corona theater that goes on just to, a lot of people are are not really bothered, but for those that are very concerned, I think we need to be sensitive to their concerns. And so having a little bit of the corona theater, I think, is important for them.
Right. Well, I agree. And I think that, I'm just curious from your perspective, do you anticipate an uptick in terms of the number of patients coming to see you? Or do you think because of the economic impact that there might be a little bit of a slowdown?
I think it's really hard to tell. I do think that there's going to be a reluctance of cosmetic and non-cosmetic patients to show up in a doctor's office. The more medical the facility, I think the more reluctant people will be to show up in that setting. It won't be reassuring. It'll be concerning to them because they'll see the hospital as a hot zone. And they already, you know, elderly patients see our office as a hot zone, whether that's the reality or not. So I think people will be slow to get back into doctors' offices and even slower to get back into the hospital as a consequence of this.
Mm-hmm. I agree.
What do you think?
I agree. I think, you know, I think about it in two ways. I mean, one, I think about the, you know, the desire to, you know, because as we talked about before doing this, that for people who are seeing themselves more because of all the screen time, I think the types of procedures that they're going to be doing are differently. I think from our perspective, we're going to be spending more time with each patient and reducing volumes, and calling patients beforehand, pre-screening them, so to speak, talking about, you know, doing anything that, talking to them about, making sure that they don't have any fever or anything associated with the virus before coming in, encouraging them to wear a mask into the office, keep doing our part in terms of social distancing once they're in the office. We're going to take measures to check patients out while they're in the room. So we're going to try to streamline the whole process and minimizing the amount of time that they're in the office and the number of people that are in the office. We're probably going to be staggering the support staff that are in the office at the same time as well. I think we're going to be doing a lot of virtual consultations and follow-ups. Go ahead.
Testing?
No, are you confident with the testing that, I know you're doing the testing? Are you confident with the testing that you're doing? And are you looking at immunity, or are you looking at positivity in terms?
Yeah, you know, there's two kinds of tests. There's PCR testing, that is testing for active virus, and that has to be sent off. So we're doing that. And we've tested a lot of people. Now, I want to test my cat because I want my cat to be the second cat in the country that tests positive, because there was a cat in New York, you know, I think a lion or a tiger that tested positive. And I think Max is actually a small tiger. And he probably is, he sneezes a lot. I'm thinking he's probably positive. So other than Max, though, we have tested quite a few people for the virus. And then there's antibody testing, which you get an immediate answer. And we've been doing that for a week or so as well. And that tests for the antibody. So we've been offering the testing just to reassure patients. I don't think it's necessary really for a small segment of patients that are caring for somebody who is very vulnerable, like a 90-year-old or somebody who's really sick with some type of, you know, immunocompromising disease.
Right.
Somebody who's very ill or susceptible, and you're caring for them, I think, you know, you're going to feel better knowing that you're not going to give them the virus. But other than that, I mean, a young, healthy person, for their own sake, I don't think the virus seems to be that, have that high in morbidity.
So you're screening your staff as well, obviously.
I screened my staff just so that to reassure my staff.
Got it.
And also to show them how to do the testing so that when they do it on a patient, they can do it on a patient. So when we started doing it, there was this huge appetite for testing. I think there probably still is from the response we're getting, but I wanted my staff to know, have it all demystified, if you will.
Right.
Yeah. So the testing, though, is, I think it'll be good also to keep track of it, to be able to contribute to the overall database, so we know what the prevalence is.
Right. No, it's interesting, some of the numbers that are coming out of New York right now in terms of the number of people who have been
Yeah, I mean, it's because, I mean, it's because people are inside in New York, and the virus spreads inside better than anywhere. The whole cruise ship experience should show that.
Hmm.
So, what do you think will be the effect of this in Houston, and especially with the problem with the collapse of oil prices, at least temporarily?
No, I mean, I know we've talked about it. I mean, it was interesting hearing your experience, having been here in the 80s. When there was an oil crisis there. I think people are going to be more selective about what procedures they're doing. I think um, I think they're going to reduce the number of procedures that they're doing, but I think that there's still I mean, based on the calls that we're getting, there's still a demand, but I think that patients will probably space the intervals between the number of treatment sessions that they do, and they're going to be more selective in what procedures they do, and that a lot of that will depend on, our recommendations as well, and we try to take that into account whenever we're visiting with the patients and going through their options. Is first question is, what is your budget?
Mhm.
What are you?
I
So.
I wonder, what is your experience doing virtual consults? Do you think you can do a good dermatologic consult or a good cosmetic consult like this, using telemedicine, as opposed to actually seeing the person in real life, uh, and not only seeing in real life, but being able to touch a lesion or touch the face and, get a feel for the skin?
I mean, we've been doing them. I don't think it's ideal. I mean, I think, for one thing, I think unfortunately now when the patients are coming into the office, we're wearing a mask. So to me, for a new patient consultation, that takes away a little bit of the, getting to know each other, so to speak. But it's, I mean, the security and the clarity is very good for when we're talking about the majority of what we do above the neck in terms of evaluating certain types of birthmarks or certain, some of the different conditions that we were just discussing. I think where we're not as good is discussing outcomes in terms of being able to show patients visualizations of what they can expect in terms of the progression of the treatment, what type of what the recovery is going to look like. I mean, we've been struggling with that. We've been pulling out, some before and after binders and trying to show them to the camera so patients can get a sense. But I think showing patients in terms of expected outcomes is a little bit challenging. I mean, it's good, but it's not the same thing as being able to see the patient in the office. I miss that, definitely. Looking forward to getting back to that.
Do
And
you, would you feel comfortable evaluating, some type of skin lesion? If I said, here, look at my mole, look at this lesion, whatever, would you feel comfortable in a normal telemedicine consult saying, don't worry about that, or you need to come right in and let me do a biopsy of that? What's your level of confidence?
I mean, for the most part, we've been doing mainly rashes with telemedicine. We typically, we're doing a lot of the dermoscopy, which is an imaging device that we use in the office, ideally when evaluating different types of lesions. And so obviously we're not able to do that virtually. So, I mean, starting next week, we're going to start bringing patients in for evaluation in person of various skin lesions, because it's, as you say, it's not the same as what we're able to do virtually. And we
Hmm.
can't give patients that level of confidence as we can when we see them in person.
I see. And what kind of platform are you using? Are you using your EMR platform, or are you just using
It's a
Skype?
platform. It's a platform called Clara, and it's a very secure It's a secure HIPAA compliant platform. I'm happy to share it with you. That ties in with our EMR system.
Okay, yeah. Yeah, our EMR has provided a telemedicine platform free of charge temporarily. Um, I don't know if it seems to be more cumbersome than just
Right.
us, but um, uh, you know, I just do what I'm told by the office
Right.
staff.
Well, it's
For
great to
most
see it.
of
Go
you,
ahead.
it's good to it's actually, I can tell. um, I have a good number of out of town patients, and I can especially for body things, if a woman has a breast problem or breast cancer reconstruction or, a rejuvenation kind of thing, I can usually tell what needs to be done over the phone between talking to her and over a Skype call. I can usually see well enough to be
Right.
able to tell what needs to be done with the caveat. When I have an out of town patient, I'll usually, um, you know, tell the patient, look, here's our plan, but of course I'll see you the day before, and we may change depending on what things look like, but in real life, but this is what I think is going to be the.
Exactly. And patients have been happy with that. I mean, I've been amazed at how patients have responded to it and have, booked procedures for the future, knowing that we're going to be opening
Mhm.
based on our interactions virtually. And so I think it's nice from that perspective that we're able to continue at least in that format for the time being.
Yeah. Do you both do? I'm reading the questions here. In the new city, in the other city, um, anybody who wants to see Dr. Friedman in Los Angeles, I'm happy for him to come out, and I have a place for you to stay and
Thank
a
you.
room, and so you're more than welcome to come out here.
Would love that.
Yeah.
That's
Uh,
great.
yeah, it's years ago. Dr. Friedman thought about moving to Los Angeles, and he made a smarter decision and moved to Houston instead, where I think he's done really well and been a real asset to the community in Houston. So, but you still could come out.
I, it's very tempting. She said New York City. Yeah, I do actually see
Oh,
patients in New York City.
New York.
I still do. Um,
Oh, I didn't know that. How often are you in New York?
I mean, I've been going up about every 2 to 3 months. And
Nice.
it's nice because obviously my wife's from New York, and so the kids get to see their cousins, and so that's been great. And
Oh,
I did my I did my fellowship in New York, so I will see patients in Dr. Geronimus's office.
very
Uh,
nice. Very. So they're still locked down medically in New York, I take it?
yeah, yeah, we're still locked down. Hey, hey, Dr. Frank, how are you? So good to see you.
Where is he?
He is in the city. Dr. Frank, he is on the Upper East Side. He's
Uh-huh.
we did residency together. He's got a celebrity clientele as well, and he's been sharing his experiences. Um, he actually is recovering from COVID and very healthy, active,
Oh,
uh,
well,
and so it kind of took. He's been sharing his experiences, and it's been well received, and I think we're all ready to get back into the saddle as soon as possible.
yeah, I think that's the sense that I get. Although yesterday I was able to travel all over town. Literally, I visited 5 offices yesterday all over town, and was back before 2 o'clock. So I mean, other than at 2 o'clock in the morning, I don't know when else you could do that in Los Angeles. There are some benefits.
Exactly. Well, hopefully we can get you to come visit us in Houston sometime in the near future when things settle down,
Yeah,
and it's always great talking with you and hearing your insight. And I always encourage patients to come see you when they're have the ability to go out to California, because I think your surgical skills are incredible, and I hope to continue to work with you. I think we lost him. All right. Well, thanks so much.